for coming out tonight. It is with great pleasure that we're doing this forum. We have been trying to do them every 2 years, but then COVID really threw a spanner in the works, so to speak. So yes, hopefully we'll get back on track with doing them every 2 years, and it's just great to see everybody and to sort of be able to come over. Flew over from Sydney yesterday, and yes, it's great to be here, and we had a lovely sunny morning this morning. So,
after you bought the rain, you mean?
Yeah, well, I thought you might have needed it, so. So we're going to have a very action-packed agenda for you. So I will start off and just give you some information about Neuroendocrine Cancer Australia, of which I'm the CEO for. Previously, up until October last year, I was the project officer and nurse educator, and then Simone Layden decided that it was time to pursue something else after 13 years of being the co-founder and the CEO, and she has done an amazing job as far as setting up the Neuroendocrine Cancer Australia, or it used to be the Unicorn Foundation. So we're eternally grateful, and she's very well deserved to get her AM with the King's Birthday Awards. So we congratulate her, and just are very grateful for everything that she and her brother John have done. But she's remaining on the board of directors, so yeah, she's still part of us. So there was something I was going to say, but I can't remember what it was, but doesn't matter. It's, we want to have this as, well, formal but informal. So we'll have the speakers first, and then we'll have a Q&A time afterwards. So if I can ask that you have your phones on silent, just so that we don't have any noise happening. And as far as housekeeping for the toilet, it's outdoor to the right, up towards the desk, go to your right, and then it's directly on the right there with the green doors. So, and feel free if you do need to get up and go to the toilet to do that. So, so our speakers tonight will be myself, and then Joe and Lauren will give you an update on and an overview of their role. Chris Lomma, who's a medical oncologist, but I'll introduce him further just before his presentation. Dr. William, or Bill McDonald, will be talking about nuclear medicine and CERTs, the internal radiation spheres, and then Dr. David Ransom is going to talk about clinical trials, but I'll go through a little bit more of their bios as we get to them. So I will start off and just work out if this mouse works. Yes? So I just thought I'd give you an overview of neuroendocrine cancer with the current stats that are available and survival rates. So as you can see there, it's not a cancer that is rare. So according to last year with the Australian Institute of Health and Welfare, there were 5,437 new cases of neuroendocrine cancer, and it's been going up each year. And you can see it's more than ovarian, testicular, cervical, multiple myeloma and Hodgkin's lymphoma. So it's very interesting to see, so when you're comparing and people just say, well, it's a rare cancer, it's not a rare cancer. And it's actually the 7th most common cancer in Australia when you look at all the sites that neuroendocrine cancer can occur. And as we all know, we call them NETs, which is also, we say, is nearly everywhere tumour, because they can occur anywhere. So the 5-year survival rate is 51%, and comparing that to breast cancer, which is 95%. So we want to really get an earlier diagnosis, and so that we can have a much better survival rate for everybody with NETs. And it affects men and women both equally from the age of 15. So just a few more of the statistics. 30% of patients live 300 kilometres or more from the closest centre of excellence or the treatment centre. There's 1 in 55 Australians who have a chance of developing a NET. An interesting 30% of patients are diagnosed in the emergency department. We're not 100% sure what that 30%, how it comes about, but it could be because patients have been misdiagnosed for so long. They've gone to their GPs, they've had problems, they haven't been diagnosed, they present to the emergency department because they've got pain or potentially a bowel obstruction or something else as far as the symptoms, and they've been diagnosed whilst they've been there. Also, a lot of the cases when they've got appendicitis, that they've actually found when they've opened up the appendix after removing it, that there's actually neuroendocrine cancer in there. So there's a lot of things that we're actually finding out. So there's over 24,000 Australians who are living with NETs, and 1 Australian is diagnosed with neuroendocrine tumour every 2 hours. The average Australian waits 5 years or more to get a correct diagnosis. And then there's 60% of patients are at stage 4 by the time they are diagnosed because of the long wait and the potential that sort of, it has been missed and it's just been growing there. So that's a pretty staggering statistic. So just as far as what we do, our vision is to be champions of early diagnosis and a cure. And our mission is to assist and support patients and their carers through support groups and access to networks of expertise. We also lobby to access new and appropriate investigations and treatments, and we've been doing a lot of lobbying with the politicians, local and federal, and we're starting to get a bit of traction that they're actually saying, we've heard about neuroendocrine cancer, but we still need to push more so that we can get funding and there's equity for our patients. I'll go into that in a little bit more shortly. We also want to raise awareness and knowledge with the medical community, and as we know, there's a lot of the medical community who have no idea about neuroendocrine cancer. We had a patient recently who contacted us who is actually an intensive care specialist and works with a lot of respiratory diseases, and he's been diagnosed with a neuroendocrine tumour and he'd never heard of it before. His daughter is a nurse, she'd never heard of it before. So there's 2 medicos that sort of we could just name straight away. And we want to encourage and support research in the area of neuroendocrine cancer. So we do that through the Planet Registry AusNet, which is a nurse-led shared care model, which we'll be embarking on very shortly. But I'll go into that in a tiny bit more detail shortly too. So as far as what we do, patient support, we have the NET Nurse Support Helpline. Come in. And on average, we're getting around about 180 contacts a month. But recently, we've embarked on our awareness campaign, and it's actually doubled as far as the numbers coming through. But the problem with that is we've got 1 NET nurse for the whole of Australia. So for 24,000 patients living with neuroendocrine tumour, we've got 1 nurse who's available Monday to Friday to take all those calls. So it's not really equitable, and that nurse is actually funded by all of you. So we don't get government funding for any nurses. Our resources, we've increased with 2 explainer videos, and at the moment we're just doing a script for an explainer video, so they're animated on the peptide receptor radionuclide therapy. There's also support groups, of which we've got some of our wonderful support group facilitators here, so I encourage anybody who doesn't go to the support group and would like to, please contact Doreen over there, Leanne there, and Marg there. So Marg's in Bunbury. So please reach out, and they're fabulous with everything that they do, and it's wonderful to have local support. We also do a national Zoom meeting monthly so that we can access people from wherever they are. The private Facebook groups, we've got over 1,700 active members in that, and we remain the main referral service for NET patients around the country. And the Cancer Council refers a lot of patients to us, which is great. And I know there have been issues with the Cancer Council over here of the past, but it's now good, which is the way we like it. So as far as research goes, we've got the Planet Registry, which is being run, and David is the principal investigator for Fiona Stanley. And so patients who have neuroendocrine cancer get recruited to the Planet Registry, and they consent to that. And once they're in the Planet Registry, all the information that are their clinical notes is submitted into the data registry so that we can get a good overview or a good collection of information about all the neuroendocrine cancers around Australia, so that we can look at what the types are, the numbers, and how we can better our research by looking at different areas. And also when you're on the Planet Registry, you get an app that you can download onto your phone, and that you can do your Bristol Stool Scale, which is your poo chart, your quality of life, and your performance status, and also your vitals, so that we can look at sort of your body mass index and everything. So it's very useful, and we're hoping to expand on that. AusNet is going to be at each of the 5 centres around Australia that are the main centres of excellence. So we've got Fiona Stanley here, Queen Elizabeth in South Australia, Peter MacCallum in Victoria, Royal North Shore in Sydney, and Royal Brisbane in Queensland. So each of those sites will have a nurse that's going to be working with the AusNet study, and then we have our nurse Simon, who's over here, who will be working with all those sites, and it's going to be shared care. So whatever the management plan is that's discussed at the multidisciplinary team, that will then be shared with the GP so that everybody's kept in the loop and knows what's going on, and the patient is forefront with discussing those management plans. There's also treatment in the community that we're just starting to do with Ipsen, so we're looking at how we can look at the pathway for neuroendocrine cancer, and then we can map out ways that potentially we could raise awareness and also increase the time or decrease the time to diagnosis. So that, but that's just starting off. We've also been working with Melbourne University for a menopause study, which is very interesting because, I mean, a lot of the patients have flushing. So we don't know whether for the female patients it's flushing because you've got menopause or flushing because you've got neuroendocrine tumours. So it's never been studied before, so we're really keen to see what comes out of that one. We've also just got an intern who's arrived in Australia from the Netherlands who's going to be doing a communication and treatment pathway with us for 6 months. So that'll be really interesting, and she's been working on pathways for breast cancers over in Northern Europe, and so we're looking how we can work with her and get some information. And she's going to be predominantly looking at patients, since we've had the optimal care pathway launched in January, that looking to see whether there's any changes as far as the way people are managed. And then there's a genomic study that we're sort of waiting to see whether we get approval for funding. So that we'll be looking at genetic testing for all neuroendocrine patients so that we can look at risk factors and also not just the, if it's a hereditary. Education, we've got our GP education modules, and we've had over 3,000 healthcare professionals complete that, and it's fully accredited. So if you've got a GP that hasn't done the modules, let them know that they're out there. They're free, they're online, and they get, I think it's 10 points for it. We've also, as I just said, funding. There was one off for a national awareness campaign, and I'll show you our campaign shortly. And we're having all this recorded so that we can do more education, and also we've been doing the recordings for patient stories, of which Alex up the back there, and I'm just sorry, forgotten your name. Mark. They've been doing filming, so but we're hoping that's going to really sort of get out there and really get people aware of us. There's in-service that can be available to nurses and GPs online, and so we can zoom into them and do education with a general overview. The Net Patient Education Program, of which hopefully some of you've been part of, was launched in October 2022, and we're running 3 of those a year. So it's a virtual 4-week course that goes for 2 hours each week, and it goes through everything with Living with NET. So it goes through all the treatments. We also have with everybody that's attending that, being able to share their experiences and learning from each other as well. But we cover everything from financial toxicity to all the treatment options, dietitian, exercise, and fatigue, all those things, so that everybody can learn about it and share their experiences. We do a lot of conference presentations, and also we're hoping that we can put together some dietitian education modules, which we're looking to do with Cummins, which is Canada, New Zealand and Australia, because there's such a lack of experienced dietitians around. So if we can put that together, hopefully we can provide some education for them. I'll just whiz past that. So with Advocacy, we've got our National Action Plan, which is what we're lobbying with the government for. So what we want is the NET specialist telehealth nurses, so that we get one in each stage, hopefully more. Information and resources, which is part of the awareness campaign that we've got now. The education and healthcare for professionals, so we want to make sure that we can continue to provide that. The national awareness campaign, we've got the funding for 1 year, but we know that we need to do more than 1 year to get the word out there. The optimal care pathway has been achieved, and that was, as I said, launched in January. So with those, there's 3 actually parts of it. So there's a very comprehensive one, which is about 72 pages, but then there's a quick reference guide, which is 4 pages long, and that's built predominantly for GPs, so that they can see if somebody's got the symptoms, what sort of tests they should do, timeframes and the referral pathway. So it makes it easier because a lot of GPs don't know where to refer to. We want to make sure that we've got more centres of excellence around Australia and also targeted research. So I will move on to, attempt to move on. Sorry. It's not a very compatible mouse. So our National Awareness Campaign, we've decided to come up with Consider the Grey. So nets are not just black and white. So we want to make sure that people are thinking, you know, think outside the square. And we've made it so that we've got all different types of races, ages, gender, and with the camouflage, it's because neuroendocrine cancer camouflages itself as other things. So it could be irritable bowel, it could be menopause, it could be asthma, it could be heart problems. So in each of those camouflage, we've got the symptoms so that it can draw attention to people so they know about it. We're also putting in for the Senate inquiry, and I think those who have been looking at our website and also the Facebook, we've asked for your input or for you to submit to the Senate inquiry. So the more people that are putting the word out about neuroendocrine tumours, the better it is that we're actually going to get noticed. So, and we need your input. If you want to be part of it, the terms of reference that we need to cover are like cost, geographical location, support, all the simple things that really, you know, every patient deserves to have. MSAC, which is looking at the Medicare things, sort of where we're looking at scans that haven't been, the descriptors don't allow neuroendocrine tumour patients to have the scans that they should be having and be able to be rebatable. They have to be paying out of pocket. So we want to get all those things sort of reviewed so that we can organise to get people to not be out of pocket. There was also another meeting I went to, biosimilar for chronic complex disease summit at the Parliament House, and that's looking at drugs that are not sort of the biological, but they've been made to be very similar so that it's more cost effective. But there's a lot of things that we need to look at. So we really, really, really want everybody's stories and interviews, and that's why we're doing these patient forums, and we've got our lovely Alex and staff who are doing filming, and also Jade, who's with the PR company working with us. And we've also made some little just flyers that can be put into the hospital, and we'll be giving them to Joe and Lauren so that people can be introduced to Neuroendocrine Cancer Australia and contact us. And it's got scan QR codes on them so that people can just go into various important documents and makes it easier without having to search the internet. I just want to do just a very, very brief, quick update on Somatostatin Analog, so the butt harpoons. So eShine program closed on the 30th of April, but the Novartis is still providing education for GPs if they want to be trained to do it. So if there's any issues that you have, just contact us and we can work with you and Novartis. Ipsen still has its home injection program, and it's also providing a new program for gaps, which is the cost of the PET scan if it's not, and this is only Ipsen, not subsidised by Medicare or by a hospital, or there's unreasonable waiting time list for subsidised PET scans, or an unreasonable amount of travel would be required to access subsidised PET scans. So they're looking at ways that they can assist. So eShine used to cover chromogranin A and also the PET scans, but now that that program's not there, then people are having to pay, especially for the chromogranin A. And the generic lanreotide has been launched on the 1st of August, so it's the same as your Somatostatin lanreotide, but it's a generic, it's not as good needle, and it doesn't have a home injection program. So you just need to be aware that if that it's being ordered, that you know what you're getting, so that yeah, it's easier for you to get your injections done by the appropriate person. And the last thing I wanted to show you was one of the patients. We did a talk to one of the pharmaceutical companies, and he presented his story, and I think this is so true, sort of that everybody here You're going through your, I hate the word journey, but you're going through your experience and you need to drive your bus. So this is the unicorn bus that everybody needs to drive. So that's my presentation, and I shall now hand over to Joe Keyser and Laura Knight, and they're going to talk about the role of the rare and less common cancer nurse clinical nurse consultants. And so Joe and Lauren are the clinical nurse consultants for rare cancers across the statewide cancer network of West Australia and are based at the North Metropolitan Health Service. With over 20 years experience across various senior cancer nurse specialist roles and cancer streams, Joe and Lauren coordinate and manage transitions of care and support for the patient and family across the oncology treatment pathway and provide expert nursing advice and support to other healthcare professionals. Their presentation today will describe their role as cancer nurse coordinators for people with rare and less common cancers. Thank you. And I'll get out of that. If I can get the mouse to move.
Yeah, I think we're going to take that actually. What you miss. Thank you.
If you go down the bottom
There's
of
a
the
little
screen.
slide screen down, two to the right, that one.
Thank you. Thanks, Bill. Thanks, Meredith. Hello, everyone. Thank you for joining us this evening, and thank you to NECA for the opportunity to present tonight. Many of you in the room may already know myself or Joe, but perhaps not clearly where we fit in the health system and how we work in our privileged roles to provide support and advice to cancer patients, and specifically those diagnosed and undergoing treatment for NETs. We are based in Perth, but have strong links to all the regions in WA. We are employed by the Cancer Network WA, previously known as the WA Cancer and Palliative Care Network. And the network was established way back in 2007 by WA Health. It was based on a major health review of cancer patient care in WA that resulted in the WA Cancer Services Framework. This review identified a need for coordination of care for cancer patients who see multiple health professionals across multiple health disciplines and health services, and also for rural patients in WA across vast distances with great potential for fragmented care and many places to become lost in the system. In WA, we have a geographical area of over 2.5 million square kilometres with a population of 2.81 million, and 75% of us live in Perth. We know that rural and Aboriginal patients experience poorer outcomes, as do our culturally and linguistically diverse society. We are a vast state with a huge geographical area to cover and with limited cancer services available outside of Perth. All of this underpinned our network and the development of the Cancer Nurse Coordination Team, with an aim to ensure timely access to services, enhance communication between service providers, and improve the cancer experience for the patient. This is our team. We are a part of the wider Nurse Coordination Service, which is a team of highly experienced clinical nurse consultants coordinating care for cancer patients across tumour streams and working strategically to improve outcomes for cancer patients in WA. We have grown to a team of nearly 30 senior nurses, and we are fortunate within this team to have great backup for periods of leave and for those of us that work part-time. It ensures that we have continuity of access to support for our patients across the working week. We also have really close links with the Rural Cancer Nurse Coordination Team, and they are located in each major region of WA. This team provides local context to patients living in rural and remote WA and ensures a seamless transition of care when patients return home. So, what do we do? We are a team, as I've said, of specialist cancer nurses, and we have a bird's eye or helicopter view of cancer services in WA. We work within the multidisciplinary teams to provide information, advice and support to cancer patients and their families and carers. We coordinate care to link services and appointments, and we liaise and refer to allied health and other supportive care services. We have 2 comprehensive cancer services at Sir Charles Gairdner Hospital and Fiona Stanley Hospital, with full access for patients undergoing treatment at these sites to specialist cancer allied health professionals such as dietitians, social workers, physios, pharmacists and clinical psychology. Of course, there are many community-based supportive care options for all NETS patients as well, such as the NECA NET support nurses, Cancer Council WA, Solaris Care, and many community-based counselling services and psychology services, just to name a few that we can refer to. Where do we work? Predominantly, we are in the public system and go across the 4 major tertiary hospitals, with King Edward Memorial Hospital, Royal Perth Hospital, Fiona Stanley Hospital and Sir Charles Gairdner Hospital. We do work in both the inpatient and outpatient setting, but our role mainly lies with the outpatients, because as inpatients there is already a team of nursing and allied health staff caring for the patients.
Thank you. Hi everyone. So the commencement of our role, and I think I met many of you at the very start of this role a couple of years ago, was very green, and we're still sort of trying to work out how the role was going to fit into the health system. But as Lauren's described, we've tried to integrate it and work closely with the multidisciplinary teams that work across these tertiary centres. So where it came about again was recently, this particular role was part of the state cancer planning, so it was priority 2, which aimed to improve outcomes for people with rare cancers. And look, our role has got a long name, rare and less common cancers. We do shorten that to the rare cancer CNCs, including less common, which, as Meredith has pointed out, NETs fall into the category of less common. So I guess epidemiologically speaking, it means cancers, that are at incidence of 6 to 12 in 100,000 and 12 to 17 in 100,000. So yes, it is less common, a lot more common than some of our rare cancers. The other reason this role came about was from strong consumer advocacy for specialist NET cancer care coordinators nationally through NECA. And also the Cancer Network of WA recognised the need to provide local support and care coordination for this patient group. So, I'm a bit ahead of myself, sorry. Maybe I'm not a bit ahead of myself. Anyway, the end result of mapping over a 6-month period and discussions with lots of key stakeholders came up with a focus area for this role, neuroendocrine tumours being one of the main areas, but also other rare endocrine cancers. Cancers, the people that were diagnosed with are diagnosed with cancers that are associated with rare cancer syndromes, and other cancers, including cancers of unknown primary. Now, this is actually a really interesting side. I think for when we set up this role, it was really important to look at the numbers of NETs patients in WA so we could sort of establish some sort of base resource for meeting some of the needs, the care needs of NETs patients. So I guess this shows the spread across the state, but what it doesn't show, and incidence is one thing, so this data comes from the WA Cancer Registry. And essentially, it doesn't cover prevalence of NETs. So it doesn't show the cumulative and impact or sort of numbers of people across the cancer continuum. And I think unlike more common cancers, NETs patients can live for many years, and some of this stuff I'm not telling you anything new, but I guess I'm just reinforcing and validating this. They can live for many years with advanced metastatic disease, so there are many thousands of people, as Meredith pointed out too, living across Australia with NETs. So I guess at the end of the day, the increasing incidence and the prevalence of NETs reinforces the need for greater awareness, diagnosis and management of this condition, and along with coordinated and resourceful ways of supporting increasing numbers of patients living with NETs is part of what our role is. As Meredith has also pointed out, NETs are like nearly everywhere tumours. They occur in lots of areas of the body, and most often in the gastrointestinal tract or the lung, originating in hormone-secreting cells. So NETs are also diagnosed and treated, certainly in WA, nearly everywhere in the health system, by many disciplines across regional and metropolitan WA, but broadly can involve surgery and liver-directed therapies, systemic treatments, including your somatostatin analogs, radionucleotide therapies, targeted therapies like everolimus and sunitinib, and chemotherapy treatments. So our roles, as Lauren has said, are predominantly based in the public system, where we receive most of our referrals for NETs patients for support and care coordination. The main clinics we attend are medical oncology and endocrinology clinics at Sir Charles Gardner and Fiona Stanley, where there are high numbers of NETs patients receiving ongoing surveillance and treatment. So patients with rarer NETs are also seen in endocrinology clinics across these hospitals. So that's another place where we do meet a lot of our new patients. And also King Edward, of course, with patients with rare cancer syndromes. So Lauren and I also attend the statewide NET MDT, which is chaired by Dr. Ransom and attended by several NET specialist clinicians, including Dr. McDonald here this evening and Dr. Lomma as well. Patients are presented for discussion at this meeting via Microsoft Teams and by many clinicians from across the public and private system. So these discussions essentially guide whole-of-team treatment decision-making and ensure the delivery of evidence-based care to NETs patients regardless of where they're receiving their treatment. And of course, the health system, as Lauren pointed out as well, extends beyond hospitals, and all clinicians have a really important role in engaging with GPs and other community care providers in our work to ensure that everybody with NETs receives optimal care. So since the commencement of our service, we've been really privileged to meet many of you here tonight, but also many that aren't. We've seen over 350 patients since our service began when I first met you at that support group meeting in 2021. Meredith has mentioned, the unique biology and non-specific symptoms associated with NETs, and I know that people are going to speak more to that tonight. But what we know in our work as cancer nurses in this area is that NETs patients experience or face really different challenges often from patients with more common cancers, and experience ongoing psychological and physical symptoms. And again, I'm not telling probably a lot of you anything new here either. And I guess NETs are experienced by many patients as a chronic illness in this way. So along with that come the associated demands for ongoing specialist and GP consults, for surveillance, blood tests, imaging, and treatments. And for many patients, high levels of supportive care needs. Prognosis for patients with NETs is often uncertain, both clinically and in relation to the ability for people to plan ahead, practically and financially. Qualitative interviews. This is a really interesting paper that was done in 2018. It was a qualitative study of the perceptions of care needs of NETs patients. It was actually done by Queensland University. And people interviewed described NETs as atypical because they're often incurable and slowly progressing, and treatment is not always associated with the common side effects of other cancer treatments. As a consequence, people with NETs, from their study outcome, what they said was they don't typify normal cancer suffering, and actually are vulnerable to being overlooked in terms of their supportive care needs and need for social supports and counselling. When many patients also suffer the symptoms of carcinoid syndrome, as you referred to, Meredith, quality of life decreases even further. Added to these psychological and physical issues are care coordination needs associated with treatments being given at multiple locations and across both the public and the private system often, particularly if we're looking for scans, timely imaging. Some of these needs that were identified in this study, again, related to the practical and financial issues associated with ongoing out-of-pocket expenses, loss of income, and for some people, loss of capacity to work, and particularly considering the advanced and slow-growing nature of many of these tumours. This same study noted that the top unmet supportive care needs for NETs patients were identified as being related to fatigue and fear of cancer spreading. The rates of those reporting these issues were equal to or higher than other advanced cancers. The study overall showed that people with NETs have clinically lower physical and emotional wellbeing often than compared to general population, and rates of depression for NETs patients were also found to be 30% higher than the general population and significantly higher also than observed across other patients with advanced cancers. So I guess the other thing about depression, these feelings of the depression, they can be also compounded by the higher symptom load that NETs patients often experience, with social isolation associated with the symptoms being experienced, like constant diarrhoea, abdominal pain, and symptoms and flushing. So it's imperative then that the network of health professionals providing care to people with NETs work collaboratively together to support better quality of life outcomes. As care coordinators, and again, I'm not telling you, a lot of you, anything new here either, but we well know the challenges of what can often be experienced as a clunky system and a fragmentation and gaps in care that all cancer patients can experience. And when you consider the multiple people involved in the workup, the diagnosis, complex treatments, and the side effects of those treatments, many other impacts and many other impacts of this care, I don't think this is really surprising. As Meredith has also eloquently described, it's imperative for people to drive their own bus. You are your best advocate, but that doesn't mean you need to do that alone. I guess it's about reaching out to seek the support that you do need and the input of many people involved in your network of care to help you to better manage the emotional, the physical, the practical, financial, the list goes on, impacts of your diagnosis on you and your family and friends. And I just wanted to share this with you. I think this is quite profound and it may resonate with some of you. We borrowed this quote actually from another presenter, and it was shared by a person living with NETs. It's a journey of hope and fears, of bravery and dreams, fighting the unknowns and fighting your own body to stay alive. Thank you for listening, and thank you for allowing us to be part of the team that can hopefully support your care needs.
Okay, so our next speaker has given me a massive great bio to introduce him. So we've got Dr. Chris Lomma, who is medical oncology management of NETs. That's it.
Hello everyone. Yes, I'm Chris. I am a medical oncologist here at Fiona Stanley. If you do want more of a bio, I also work in the education building here and also at Curtin Medical School, our newest medical school. So again, thanks for letting me talk tonight. I'm going to be covering current neuroendocrine tumour treatments. So this is what I'll be talking about tonight. I'll be talking about our general approach to treatment, what kind of things we mush up in our brains when we're making a treatment recommendation. Then I'll be going through some of our treatment options, watch and wait, the somatostatin analogs. I won't be covering PRRT cert, I'll leave that for Bill. Then I'll be covering everolimus and sunitinib, but I won't be talking about chemotherapy either tonight. So as we've heard, there's lots of different types of neuroendocrine tumour and great variety in the different tumours. So this is really annoying, but a lot of medicine is trying to understand the words that we use to describe things. So there's two main types of neuroendocrine cancers, which we call neuroendocrine neoplasms. They're the neuroendocrine tumours, the NETs, and the neuroendocrine carcinomas, the NECs. And that is really, really important for us as health professionals to decide what kind of treatment and what scans we should do and the prognosis and everything about it. So that's a really kind of important thing, is getting that terminology down for us. So when we are thinking about treatment, we have a million things going on in our brain about what the pathologist has said the cancer looks like at the microscope, what the scan says it looks like, and what we hear from you guys about your symptoms, what medications you're on, whether you're in the city or the country, and all of those things we mush up in our brains, and then we try and come with a treatment recommendation. So if we go back to our definitions of neuroendocrine tumours and neuroendocrine carcinomas, you can think of these as a kind of spectrum, where on this side we have a well-differentiated neuroendocrine tumour, and we divide them into grade 1, 2 and 3. And we mostly use this information that the pathologist gives us. They give us a score called a Ki-67 score, and depending on what that score is, that will help classify them as grade 1, 2 or 3. And the further we get along on this kind of grade from low to high, the prognosis is better down this end, and then as we get down, unfortunately, it does get worse. And the cancers down this end, these slower growing cancers with the Ki-67, they grow slower, and the more we get down this end, the faster they get. And the same with the scans we do. So down this end, we're much more likely to do an octreotide or gallium PET scan, and that's much more likely to give us very good information. And as we go further along, we're much more likely to do a different type of PET scan, an FDG PET scan. And our treatment options change as well. When we're way down this end, we're much more likely to go with a watch and wait type option, or somatostatin analog like lanreotide or PRRT. And as we get further and further along, we're much more likely to think about chemotherapy. Now, I've presented this like it's all very nice and neat in this way, but sometimes we see a zigzag where you might have something here and you think it's going to be gallium avid, but it's actually FDG avid, or it might be gallium avid and grow fast, or you think the prognosis is good and it turns out that it's not as good because that's just the way it goes. So it doesn't always work like this, but this is the kind of framework we have in our head. But it's not just that, we also need to think about the location. Where did this cancer start? The prognosis and again the treatment is often dependent on where the cancer started. Is this a neuroendocrine tumour that started in the stomach or the small bowel, which is different to the pancreas, which is different to the lung? And we also need to think about what we call the volume of cancer. So a patient who just has one spot of cancer that metastasized to the liver is very different to a patient who has 50 spots of cancer all through the liver and through the bone and so on. So we need to think of all these things in our mind before we're thinking about how we need to treat the patient. We need to think about the symptoms. Is this a patient who's having some symptoms from their cancer, or a patient who's fortunately not having any symptoms? And often what we find is that over time we get these answers. So we'll see you at the first appointment and we'll think, oh yeah, this is what's going to happen. It's going to be all down this left-hand side. And then over time we might see, well actually the rate of growth that we thought was going to be slow is a lot faster. Or what we thought on the scan actually didn't check out. And so time for us is tells us about you rather than just the theory of what we've learned in the textbook. And so that often changes, we change what we do because time has shown us what we thought at the start was not actually what happened in your particular case. So that's a very important thing for us as well. So sometimes it's hard at the first appointment to say what's going to happen next time because we don't know, because we have to give it some time and see, which is sometimes a challenge. And then obviously the most important thing is you, the patient. How are you feeling? What symptoms are you having? How are you responding to the treatment or not responding to the treatment? Are you someone who's kind of happy with a watch and wait strategy and be a bit more conservative, or should we be a bit more aggressive? How hard is it to get to the treatment? How it's affecting the family and the finances and all those millions of other things that are important when we're coming up with what is the best or most appropriate treatment option. So we need to take all those things into account. Then it's not just the doctor that you see in the clinic. We'll have the MDT like we've heard about, and so we'll be there in a room with all of us talking about you guys, and then we'll go and meet you guys, and then we'll kind of put all our heads together, and 50 people will come up with a decision, taking you as the obviously the centre of that to decide what the best treatment option that we can recommend in your particular case is. So the focus of my talk today is going to be more down this end of this slide, focusing more on the grade 1 to 2 well-differentiated neuroendocrine tumours, and so that's why I'm going to leave chemotherapy out of my talk. I'm also mostly going to focus on the gastrointestinal and pancreatic nets. They're the most common what we see in the clinic. So our goal of treatment with a patient who has metastatic disease is to help them if they have symptoms, help those symptoms be as good as what we can make them, and to help them live longer. Unfortunately, patients who do have metastatic disease, if you look at the textbook, it will say it's incurable. Sometimes that's not the case, but that's what the textbook would say. So our goal is to come up with a strategy that will have a good quality of life for as long as possible for our metastatic patients. When we start a treatment, our general kind of rule is we're going to start this treatment until one of two things happens, until it stops working or it's too toxic. And again, these are all very general rules, and we change our mind as we go along and things change over time, but that's our kind of, where our head's at. How we decide whether something has stopped working is normally by doing a scan, seeing does the cancer look worse on the scan, in which case the treatment's probably not working. But also your symptoms are important. Are you feeling worse? Are things, going bad? You're more tired, symptoms getting worse. That's obviously a very important thing. And then occasionally blood tests can sometimes help a little bit as well. When we're looking at the side effects, are the side effects too bad? We're mostly relying on you guys. What you tell us are, how as you started the medication, how did you feel after? Did it cause the side effects that we were worried about at the start? Are they kind of mild, moderate, severe? Is this something where we can have a short break from treatment, reduce the dose, or do something else, or it's just completely intolerable? We just need to stop this treatment here. So that's how we kind of approach kind of patients on a day-to-day basis. So going into the actual treatment options that we have for those lower grade neuroendocrine tumours, the first one is observation or watch and wait. So this is especially useful for our low grade neuroendocrine tumours. There's not necessarily a rush to jump in and treat those tumours, especially if there's no symptoms, especially if it's in the small bowel rather than pancreas or somewhere else. And especially if there's low volume disease, there's not a lot of cancer on the scan. So maybe just watching, waiting, repeating the scan in a few months and seeing how fast this cancer is growing and getting that real life experience of what's happening with your particular cancer is often a reasonable option. So the pros to that are, well, if there's no treatment, there's no side effects, and that's good. There's less appointments, you get to see us less, which is good. And we get that real life experience of what's happening with your particular cancer, how fast it's growing on no treatment. The downside is there is a cancer there that's not being treated, and if we don't treat it now and then it does grow very fast, have we missed the boat to give a particular treatment? So that's the kind of discussion that we would have about pros and cons for that watch and wait strategy. Our second kind of treatment option that we think about for those lower grade neuroendocrine tumours is somatostatin analog, octreotide or lanreotide. This is a complex picture, but what it's showing is this is a cell, and these cancers often have a receptor on the cell, a somatostatin receptor, and then these drugs act on this receptor, and so what they do by this action is they decrease hormone release. Apoptosis is death of cell, so that increased death of the cell, which is good because this is a cancer cell, so you want it to die. They decrease proliferation, so decrease growing of the cell, another good way to treat cancer. They decrease the ability of the cancer to feed itself with a blood supply, and they decrease the cell sending out signals to other cells nearby to grow and grow and grow. So that's how these somatostatin analogues work. So that's often a good treatment option. It's most likely to work in a situation where the octreotide PET is very positive. It's most likely to work for a low grade or a low Q67 neuroendocrine tumour. It's most likely to work if there is a lower volume of cancer, and it's most likely to work, or more likely to work, in a small bowel or pancreas neuroendocrine tumour compared to other neuroendocrine tumours. Now I say that, but that's probably because it's just been more well studied in those small bowel and pancreas tumour. There's been more research done with those particular types rather than, say, lung or other common neuroendocrine tumours. So that would be, I guess, the ideal patient we would think about recommending this treatment for. So for patients who have symptoms, it's effective in about 70 to 80% of those patients in reducing flushing diarrhoea, which is obviously very good. And in terms of the other goal of treatment, to give patients more time, it is usually our first go-to drug in that kind of situation that we mentioned here, in this type of situation. It doesn't often reverse the cancer. So when we do a scan a few months later, if the scan looks the same, that's not unexpected. We don't expect the cancer to get smaller. It'd be great if it did, but as long as it's not getting worse, we say it's working. And then we would say, oh yeah, it's working, as long as the side effects aren't too bad, let's push on a bit longer. It can work for a long time if it does work, which is obviously what we hope for. Because when we start a treatment, because we're starting it with the idea that we're keeping it going until it stops working, or until it the side effects are too bad. From the doctor's point of view, if the patient's on that treatment in a year's time, that's fantastic because it's still working and it's not making you sick. If you're on in 2 years' time, that's great. It's working and it's not made you sick. So for the longer you're on it from the doctor's point of view, the better. This is a kind of weird graph. I just put it in to show you how our minds work. So this, in medical oncology, this is kind of the go-to information that we need to see if the drugs work and how we prove they work. This was the kind of first study to show that this drug slowed the cancer growth down. And in this study, half the patients got placebo, so they didn't get an actual drug, they just got pretend drug. And the other patients got the Somatostatin Analog. And so this graph of the placebo, you can see as it goes down, this is how long it took for the cancer to grow on the scan. So you can see this is percentage down the side. So if you say 50% of the patients in about 6 or so months, the cancer had grown on the scan. So the watch and wait strategy for these patients in these studies, 50% of them in 6 months, the cancer had grown on the scan. If you had the medication, the lanreotide, 50% of the patients, it was 14 months. So the advantage that it slowed the cancer down for an additional 8 months. And so that's not applicable to any particular patient, but that's the kind of way that doctors use this information to think about whether the treatment's useful or not. This is how we do our studies, basically. So the side effects, they're generally not too bad. It's one of the milder drugs we give. Now that's easy for me to say because I'm not receiving it, so I appreciate that the experience might not be like that for many of our patients. Often the side effects can be short term and we give it for a few months. The side effects are bad in the first couple of months and then they get a bit better just through time. One of the side effects, obviously, there's an injection, so you can get side effects from just having the injection. And then abdominal side effects are probably the most commonly reported, so nausea, wind, diarrhoea, tummy pain, that kind of thing, and can also affect the sugar for the patients as well. They're the most common side effects. If it stops working, sometimes we just bump up the dose or we shorten the duration from 4 weeks to 3 weeks, or we would think about switching to a different treatment option. Our next treatment option would normally be PRRT or SIRT, and I'll leave that one to Bill. But one of the things we might consider after PRRT or instead of PRRT is a drug called everolimus, which is a tablet. These are some of the brand names that you might get. They're all, from my point of view, they're all exactly the same. And again, this often delays the cancer growth but doesn't necessarily reverse it. And it's a daily tablet. It's most likely to work in a patient who the symptoms aren't too bad. Again, in the gastrointestinal, pancreatic type neuroendocrine tumours, after another treatment has stopped working, so it's a second or third line kind of a plan B or C type drug. In the low to intermediate grade ones that we're talking about, It's on the PBS for pancreas only, but I think we have funding to give it to everyone. Is that right?
We have Palliative approval.
Yeah, so the state government has kindly agreed to fund it for all the patients, even though the federal government doesn't. Anyway, that doesn't affect you, but a lot of our life is thinking about the funding for everything that we do. Side effects, I would say probably worse or not as good as the somatostatin analogs. So we see things like tiredness, mouth ulcers, diarrhea. Then there's rare things like lung inflammation, infection. Those are rare. Another common drug we use is sunitinib, again taken as a tablet. Dose can vary. In the trials, they was given daily, but when we use this drug in other cancers, like kidney cancer, we give it a schedule, 2 weeks on, 1 week off, or 4 weeks on, 2 weeks off, something like that. So sometimes, depending on how the tablet is affecting you and what side effects you're having, we might think about a different strategy, take it for 2 weeks, have a week off, or something, maybe drop the dose, something like that. Again, mostly in the pancreatic neuroendocrine tumours. Again, doesn't often reverse the growth of the tumour, but can stop or delay it. And again, works best, a bit like everolimus, when the other treatments have stopped working, low intermediate grade, again, the pancreatic neuroendocrine tumours. Side effects, pretty similar to the last ones, diarrhea, nausea, can affect the taste, can make you tired, can affect the blood pressure and the blood counts. So for these patients who are on everolimus or sunitinib, we would normally require a blood test every 4 weeks, check to make sure it's not affecting your blood count and so on, and then if it's all good, continue on your treatment. Sometimes if we're initiating treatment, we might do the blood test a bit earlier, 2 weekly for a bit, and then 4 weekly. So just to summarise what we've talked about, so the neuroendocrine tumours, as we've heard, there's a lot of variety, so a lot of things we need to mush up in our brain when we're thinking about treatment recommendation. We need to think about where did it start. Is this a small bowel neuroendocrine tumour, a pancreatic one? What does it look like on the scan? Is there a lot of cancer? What does it look like under the microscope? What's the grade that we hear from the pathologist? What symptoms are you guys having, and about the patients themselves, everything about them. And then we can mush all those things up in our brain, have a chat with other members of the team, and then have a chat with the patient, and then think about a treatment recommendation. So thanks very much.
So our next speaker is Dr. Bill McDonald, and he is a nuclear medicine physician at Fiona Stanley Hospital and Royal Perth Hospital. He is the head of molecular imaging and therapy at Fiona Stanley and executive director of Imaging West. He's also been the president of the Australasian Association of Nuclear Medicine Specialists, and prior to Fiona Stanley opening, he was at Fremantle Hospital with Professor Harvey Turner. Since 2002, he has been in coordination of PRRT services in WA and regularly participates in the NET MDTs and is actively involved in NET trials, including control NET. So, with pleasure, Bill.
Thanks, Meredith. You're going to give us a score?
Oh, sorry. Have we got a score?
It's 2-1.
2-1.
2 not English.
England.
Sam Kerr scored, and 2 to England.
About 15 minutes to go.
Yeah.
Well, there you go.
And another one, one more.
We were going to try and live stream it. We thought it'd be too distracting.
Okay. Actually, I'm no longer head of the service. I
sorry.
it was too long in the tooth. I've passed that pleasant job on to someone else. But so I just want to tell you a little bit about what role nuclear medicine has in the treatment of NETs. I recognise some faces in the crowd here, and others I don't. And I'm going to assume that you know a little bit about PRRT, which is peptide receptor radiotherapy. It's been around since 2000, or it was first used in Holland in the late 1990s. And it's now become a very common treatment for patients with NETs. And many of you indicated on a questionnaire that you'd like to hear a little bit more about CERT. And so I'm going to focus primarily on that during this talk, with a little bit about some research updates at the end. And so just starting with liver metastases. A metastasis is where the cancer has spread from its original starting point to somewhere else. And about, or at least 30%, up to half in some series of patients with NETs, have got spread of the NET to the liver at the time of first diagnosis. And the liver is not the only site where NETs spread, but it is the most important site, mostly, where NETs spread. And when NETs spread to the liver, unfortunately they tend to spread in more than one place, and so it's not as though there's a single blob that you can cut out and cure the patient with. So most of the patients with metastatic NETs that we see, the NETs have spread to multiple points in the liver, and it's incurable with surgery. And whilst NETs in the liver is not the origin of the NET, it's not where the NET began, it becomes the most important organ in the body to consider treatment for. And so when NETs are spread to the liver, our therapy is often focused on controlling the disease in the liver, even though there might be NETs elsewhere. And when you're considering treatment of cancer which is in the liver, you can look at it from a couple of different perspectives. One is that you can say, well, we're just going to really target the liver here. And there are a variety of ways you can do that, and we call them liver-directed therapy. And the most obvious of those is surgery. You know, surgeon goes in and chops out half your liver and throws the tumour in the bin, and then what's left behind doesn't have tumour in it. But you can also stick little probes into the liver through the skin. A radiologist does that, and sort of fry them with microwaves or freeze them with nitrous oxide. And you can pass a catheter into an artery in the groin, thread it up through the body, get it to turn a corner, go down the artery that's supplying the liver, and squirt stuff into the liver through that catheter. And so that's called transarterial therapy. And that's what SIRT is. I'll get back to that in a minute. Or if there's cancer in the liver and lots of cancer everywhere else, then just focusing on the liver might not be in the best interest of the patient. So then we might consider treatment for the whole body, and we call that systemic therapy. And that can take a variety of forms. So PRRT, which is what I do, is injecting you with radioactive stuff. But you can also take chemotherapy, either an injection or tablet form. And then there are other treatments which Chris has just told you about, everolimus, and which aren't quite chemo, but they're still things that you take in tablet form, and they're called targeted therapy. Now, an important thing to understand about neuroendocrine tumours is that they are very vascular. They have a very rich blood supply. And so when you do, in this case, a CT scan, this white stuff is X-ray contrast, or dye, and you can see that it's in a large amount in the aorta, which is the main blood vessel leaving the heart to supply the organs of the body. And this is dye spreading through the liver along the blood vessels, and here is this neuroendocrine tumour there, which is showing what we call an arterial blush. And here's another one. So an arterial blush, again you can see the dye in the aorta here in rich amounts. And then if you wait a little longer, the dye has been propelled through the body by the bloodstream, and there's not as much of it in the aorta. This is the same patient. And you can see that this arterial blush has disappeared, and we call this washout. So neuroendocrine tumours, there's a rich blood flow to the tumour, full of whatever you've got in the blood, and then if you wait even a few seconds, that all washes out and not much is left behind. And so that's an important principle that we can use when we're wondering about what therapy to give. So here's SIRT. A radiologist puts a catheter into usually the groin, an artery in the groin, threads this catheter up the aorta. Blood is coming down the other way, by the way, so it's going against the flow of blood. Finds the artery that supplies the liver, passes the catheter into the artery that supplies the liver, might get very close to the tumour, and then we can inject stuff which passes through the artery, supplying that portion of the liver and fills the tumour with whatever you want to inject. In the case of SIRT, that's little beads of radiation, and the usual radioactive chemical that's on the SIRT beads is one called yttrium. We used to use it with PRRT many years ago, but we don't anymore because it created some problems. But if you're just sticking it into one part of the body, you can get away with it. And it's a very strong form of radiation, which is kind of what we want. So SIRT stands for Selective Internal Radiation Therapy. It was actually pioneered, it was developed in the first place in the world to ever do it was Royal Perth Hospital by a guy called Bruce Gray about 25 years ago. And the company which developed out of that is called Sirtex, and they market a form of radioactive bead called Surspheres. But there are other companies in the world now which make similar things. This one, Theraspheres, comes out of Canada, and instead of little sort of resin beads, they use glass beads. And this one, Quorum Spheres, that comes out of Holland, and they use resin but with a different kind of radioactive chemical on it. And so because there are many different kinds of radioactive beads that you can now put into patients, a more generic term than SIRT, which is kind of specific to this Sirtex corporation, is now sort of in vogue, and we call this whole class of treatment radioembolization. We embolize the tumours with little beads containing radioactive stuff. And if you want to get even more technical, we now tend to refer to it as transarterial radioembolization. And there is another form of treatment that you can give in exactly the same way, which doesn't use radioactive beads, it uses chemo, and that's called transarterial chemoembolization. And in fact, you can even inject just the beads without any radiation or chemo on them, and that's called bland embolization, but that's not used so much anymore. So, who gets SIRT? Well, the most common group of patients who get SIRT are those with cancer that started in the liver. We call that hepatocellular cancer. That's the David Bowie form of liver cancer. And that doesn't respond well to other forms of treatment, and so we give SIRT several times a week to patients with hepatocellular cancer in Perth. And there's a different kind of cancer which starts in the liver called cholangiocarcinoma, and they get SIRT frequently as well. And then the other group of patients who get SIRT are those where the cancer has started somewhere else and spread to the liver. And the biggest group of those patients is standard old bowel cancer. You know how you get the bowel cancer screening kits from the government? Well, that's a cancer from the bowel. It's different to NETs, and that commonly spreads to the liver. And when that's not treatable with surgery, then those patients will not infrequently get SIRT. And that's often combined with chemo at the same time. Then patients with NETs, they might get SIRT. And then there are other patients where the cancer has started in the breast or in the pancreas but gone to the liver, and they might get SIRT as well. So we don't really care what kind of cancer it is. If it's in the liver, it can be treated with SIRT. And if we look at NETs in particular, there's growing data on how well it works, and this is a publication recently from a group in Holland which looked at more than 1,200 patients with NETs who were treated with one form or another of SIRT, and it was possible to induce what we call disease control in about 80 to 90% of them, which is an effectiveness similar to what we get with PRRT. And now, what disease control means is sometimes the tumour will shrink. It almost never goes away completely. Sometimes the tumour will shrink, and if it does, that's great. But sometimes we don't shrink the tumour, we just stop it. And in someone whose tumour was growing beforehand, stopping it is still a reasonable outcome. And the combination of tumour shrinkage and stopping it in its tracks is called disease control. And when you get disease control with SERT, it lasts for about 2 years on the whole, but that depends upon many things, and I'll try and illustrate what those things might be in a minute. And in patients who do have hormonal symptoms, flushing, diarrhoea, that sort of stuff, about a third to a little under half get improvement in those symptoms merely by treating the disease that's in the liver. We can also, if we want to, get a little bit more selective with our use of SERT, and in this patient here at the bottom there's one tumour here which couldn't be operated on, and it was decided to just go as close to that tumour as possible and to inject what would have been an otherwise lethal amount of radiation right onto that tumour. If you'd given it to the rest of the liver, the patient would have died, but because you're only treating a part of the liver, you can get away with it. And this is a thing called radiosurgery, where you actually seek to wipe out a section of the liver which contains the tumour by using very high doses of radiation just to that spot. But one of the problems with SERT is that we don't have many trials comparing it to other treatments, and so we have a whole kind of background of knowledge, but we don't really understand if it's a better treatment than some of the other treatments that we have, and I'll get onto that in a minute. It's only any good in the liver, you can't use it anywhere else, and it's best suited in patients where the principal problem is in the liver. And when there's disease outside of the liver, we often ask ourselves, is SERT the best way to go? Because with SERT, you're only fixing the liver, and the rest of the body just marches on doing whatever it's doing. And when there's a lot of disease outside the liver, we will tend to recommend a more systemic treatment option such as PRRT. If you overdo it, you can cause harm to the liver, and if you treat a lot of the liver with a lot of radiation, you can get this thing called radioembolization induced liver disease. If it's bad, you can kill someone. But what more often happens is that over time, over many years, the smaller amounts of radiation, because we don't kill many people, that we inject can cause a bit of scarring and fibrosis in the liver, and can lead to the liver becoming stiff and scarred up with time, and that can create problems, but it's usually years down the track. And so when the liver disease is widespread and we're having to use SERT in the whole liver, then we're a little bit more circumspect about recommending it. And also the workup for SERT, deciding if it's feasible and how you might go about it, is a bit complicated. It basically means you spend a whole day in hospital and you have a kind of rehearsal of the SERT for us to see, can we even do it in the first place? And sometimes we can't. Now, where there's extensive liver disease and all of these little sort of cream-coloured blobs are tumour, then we need to be careful. And you can see here, this is another example of the arterial phase image showing the tumour well, but it washing out on the venous phase image. And for this reason, we tend to use a lot of PET in patients with NETs, because if you do the CT at the wrong time, you don't see the disease. So you can use SERT together with other treatments in patients who've had PRRT or in patients who've been treated with everolimus, and that's been proven. You can give it with chemo, and we do routinely in patients with other kinds of bowel cancer. But the type of NET which responds best to chemo is typically NET that comes from the pancreas. And so when there's NETs from the pancreas that's gone to the liver and you're considering SERT, then chemo might be an option. But when the NET arose from the bowel, it's much less chemo responsive, and we generally wouldn't. And the amount of radiation you can get into that tumour is quite important. Now, this is a unit of radiation that we call Gray, and I don't expect you to understand it, but take my word for it, this is routine in radiation talk. You might expect to achieve shrinkage of the tumour if you can get at least 170 Gray into that tumour, ideally more than 200. If you can only get lesser amounts, you might get stabilisation of the disease. And if you get lesser amounts again into the tumour, you might not make that much difference. So calculating how much radiation you can get into the tumour is important in deciding if SIRT is a worthwhile option or not. And so if you look at this patient where there's disease everywhere, then we'd have to give SIRT to the whole liver, and we might induce some harm from that, versus this patient where there's disease in one spot and we could really fry that with a high dose of radiation. What are the potential risks of the treatment versus the potential gains? What are we trying to achieve with this treatment? Just slow down the march of time or kill off the tumour completely? What is our treatment plan then as a result? Are we going to inject into the whole liver or just a bit of it? And what do we expect the likely outcome to be? These are all things that we have to go through in our heads before we talk to you about whether or not SIRT is recommended. So with that preamble, this is some work from the North American Neuroendocrine Tumor Society. You've probably heard of the European Neuroendocrine Tumor Society, or ENETS. Well, this is its North American equivalent. And they came up with some treatment guidelines for patients who had small bowel neuroendocrine tumours, but this would also generally apply to pancreatic neuroendocrine tumours as well, or any neuroendocrine tumour which had come from the bowel. So as Chris said, when it's unresectable but the patient's pretty well, and particularly if there's not that much of it, you might do nothing, just keep an eye on things, or you might commence treatment with a somatostatin analog like lanreotide or octreotide. When the disease is symptomatic, however, causing you trouble in your daily life, or it's growing on a scan, we would routinely recommend some form of treatment, and that would initially usually be a somatostatin analog, and then if that wasn't working, we would switch to what we call a second line treatment. Usually now that's going to be PRRT, but it might be everolimus. Everolimus has been traditionally a bit more popular in Europe, but in this North American guideline, the majority of the PUBAs in North America tended to lean towards PRRT, with the option of using chemotherapy in tumours that had come from the pancreas. They made specific comment about embolization therapy, and they're the only group to really focus on this, and they said, look, you know, you can consider embolization therapy, but by and large, when you've got things like PRRT available, which kind of works in a similar way and kind of works as well, you might choose that because it's less complicated to give, and by and large, its toxicity profile is similar. And if you are going to use SIRT, then you can repeat it if you need to. Remember, it lasts for a couple of years, that kind of time frame. Hopefully it lasts longer, but you know, we have to live with what we get. But each time you give it, then the potential for it to cause you harm increases a bit. And in the opinion of these PUBAs from North America, if you've got access to PRRT, or everolimus or other forms of effective systemic treatment, the need for SIRT tends to diminish. And SIRT is being used more often in places which have not had access to these treatments. Okay, so that's SIRT. Now, you might remember this NECA-1 study. This was the first study which showed that if you give people PRRT, they tend to do better than people who are given high doses of octreotide when their tumour is progressing. So in this group of patients, there was about 200 something of them. The group that got given lutetium-177 octreotide PRRT were more likely to show tumour shrinkage, and they were more likely to be free of progression of their disease, free of further growth of the tumour 20 months after the treatment than the group that were given high-dose octreotide. And there's more, they get steak knives, they had improved quality of life compared to patients who were treated with the high-dose octreotide. And on the strength of this study, lutetium-177 octreotide was approved for use in North America, which it hadn't been prior to this, and Europe, and is marketed there under the brand name of Lutathera. You might have heard of that. We don't have Lutathera in Australia because there's no patent in Australia, and it means that we can give you the PRRT, it's identical, for 1/10 the cost that the Americans do. And just recently they published the longer term results of this study. So the first one was published in 2017, this is the 2021 follow-up, and this is 6.5 years after this treatment. And there was a trend towards improved survival in the group that got lutetium-177 octreotate compared to those that got the high dose octreotide, and that was about a year of extra life. Now, one of the problems with cancer trials is that after you've given a treatment and you stop the treatment, then lots of people who got the less good treatment go on and have the better treatment, and we call that crossover. And it means that after a long time, everyone's kind of had the same thing. So differences between the treatment groups tend to disappear. But for 6.5 years after the treatment, there was still some benefit from having had lutetium-177 octreotate without significant, in this group of patients, kidney toxicity or bone marrow toxicity, and that's a little bit of a problem that we deal with. And anyway, the authors of this study concluded that combined with the benefits that were seen in the earlier study that they had published, with improvement in progression-free survival, that is freedom from tumour growth, the good safety profile of the treatment and the improvement in symptoms, that this follow-up study further supported the use of PRRT as a standard of care treatment in NET patients whose disease is progressing on somatostatin analogues. And that's what we use it for here in WA. It's pretty much throughout Australia now. And it's becoming pretty much worldwide practice. And in this study from Holland, where these were the people who first developed PRRT, they've looked at, well, what happens when the disease starts to grow again? Can you reuse PRRT? And they decided, well, we're going to say that 18 months of freedom from tumour growth is worthwhile. So if you got 18 months of freedom from tumour growth, what happens if you give PRRT again? And the answer is, well, it works again. And the same number of patients benefited from it the second time around as benefit from it the first time around. And if you give it even a third time, it still works, providing it has worked before. Except that the duration of response shortens. And you can imagine that if you're spraying a cockroach with Mortine and it gets up and staggers around again and you spray it again, that eventually it might stop working. If you're putting Roundup on weeds, eventually the weeds become resistant. And the same is true of most medical treatments. So PRRT works for second and third, perhaps even fourth uses, but we have a slightly lower horizon of how long a benefit we might give you from the treatment. Providing it's not causing you trouble, happy to consider it again. And in this study from Holland, second and third treatments did not increase the toxicity profile of the treatment over and above the first treatment. There's now another study called NECA-2, which is exactly the same study as NECA-1, but in patients with nastier neuroendocrine tumours who were excluded from that first study. It's underway. We don't know what the results of that are. There's an important study underway at the moment called COMPETE, which is comparing PRRT to everolimus, because at the moment the two stand there and we can choose between them, which is better. People are tending to lean towards PRRT, but we don't know that it's better. We just think it might be. And then there's a study which I'll show you in a minute called the Lutea study. It's just finished in Holland, looking at intra-arterial PRRT, so the same catheter going up into the liver, but this time instead of squirting in beads, you squirt in the lutetium octreotate right onto the tumour, and it was hoped that that would result in bigger doses of radiation to the tumour and a better response, but unfortunately it doesn't. So in this study, in patients who got intra-arterial PRRT compared to intravenous PRRT, there was exactly the same tumour responses. Most patients did get a response, but it wasn't any better in the intra-arterial group, and intra-arterial treatment is a lot more complicated, so we're not going to offer that to people anymore. Finally, radiation has never traditionally been used, what we call external beam radiotherapy, which is the kind of radiotherapy that people with breast cancer and prostate cancer get, where they get a radiation gun and sort of fire it at the tumour. It's never really been used in neuroendocrine tumours much because it was thought that the tumours were fairly resistant to radiation and didn't work very well. But in other forms of lung cancer, there's a treatment called stereotactic radiotherapy, which is where they get this radiotherapy gun and they sort of fire it in a sort of arc around the tumour. So the tumour gets hit from multiple different directions. And it means you can increase the dose of radiation to the tumour without frying the rest of the patient. And it's often given in a fairly short session, 4 to 5 goes over a week or two. And it's become reasonably widespread in patients with other forms of lung cancer where surgery isn't a good idea. Now, NETs arising from the lung are a relatively rare form of lung tumour, and they can often be cured with surgery, but not all of them. And in this study, just recently published out of North America, so from 11 expert centres, it took them 14 years to treat 46 patients. So we're not talking about anything very widespread at the moment. But the results were pretty good. So, and similar to what you would achieve with surgery. So at the end of 9 years, 3/4 of the patients who were treated with this, providing there was only one spot in the lung, remained cured. And I suspect that this is something for those of you who have neuroendocrine tumours from the lung, or for people who present to us later with neuroendocrine tumours in the lung, this is something that we might consider as an alternative to surgery. So, going back to SIRT, it has a role in patients with NETs, but it's not our first line therapy. It's best suited, in my opinion, to frying selected target lesions rather than treating the whole liver. And we continue to rely for radiation treatment on PRRT, which has emerged, I think, as the standard of care for second line treatment of neuroendocrine tumours. And PRRT produces improved quality of life and time to progression compared to high-dose somatostatin analogues. And it has a modest survival benefit compared to high-dose somatostatin analogues even after several years. And we can repeat it with reproducible benefit and low toxicity, but with a shortened duration of response. And stereotactic radiotherapy, I think, is a reasonable treatment consideration in patients with lung NETs, who are not suitable for surgery. I think that's all I've got to say. Yes.
Okay, last but not least, we have Dr. David Ransom, who is going to give us clinical trials update. And Dr. David Ransom is a medical oncologist at Fiona Stanley Hospital here in WA. GI and NET cancers are his main focus, and he's been the principal medical advisor in WA Cancer and Palliative Care at the WA Department of Health. And David is committed to ensuring that patients have equity of access and also to the safety and quality of care. So we'd like to ask David up to present.
I'll be able to manage that, I think.
A bit of a tricky mouse.
He's a tricky mouse. Have we got an update?
So,
3-1 we
Yeah, we lost.
Okay.
I'm that down to David.
so when I was originally asked to talk tonight, we thrashed, I was thinking about what is relevant for you guys, and I thought you might be interested in what's going on in a research mind, because you're all interested in better. We're all interested in better treatments. We as treating practitioners and the nurses, we all want the best we possibly can for you. The advances in improving treatment are through research, so I thought I would give you a bit of an overview of what's past, present and future in the research area. So here we go. So I'm going to talk about clinical trials. I'm a medical oncologist, so I give drugs. You know, I don't operate, I don't give radiotherapy, I give drugs, and so that's what I'm mainly going to talk about, and that's what the focus of this evening is talking about. I'm not talking about laboratory-based research in cell lines and animals. I don't, you know, at the end of the day, it's got to work in humans with real cancers, and extrapolating results from animals is fraught with difficulty, so we don't even think about it. I'm going to talk a little bit about ComNets, then clinical trials that we've completed here, current trials open, and the international scene. So there's, in drug trials, there's really, this is a bit of a simplification, but there's 3 types of trials. If you've got a new drug, first thing you've got to work out is how much of the new drug can you give? And that's called a phase 1 study. So usually you treat very small numbers of patients, like three or 4 at one dose level, see what happens. If nothing much happens, you then go to the next dose level, you treat another 3 or 4 patients, see what happens. And if that's still okay, then you go to the next dose level, and when you get what we call maximum tolerated dose, in other words, you've got some side effects but not too bad, you decide, okay, well that's the dose, and because usually we treat to maximum till we get some side effects. So that's what we call a phase 1 study, but we aren't interested in whether it works or not. All we're doing is looking for a dose. In the next study is, does it do anything? Is this drug have any effect at all? And so in that sort of, we'd take a fairly standard group of patients, it's usually about 40 or 50, give the drug, try and work out if it's working or not. And if there is some activity, it will then go on to what was called a phase 3 study, where they're randomised. So you would take the standard of care, whatever it is, and then you give the new drug, and is the new drug better, the same or worse than the standard of care? If it's better, the new drug becomes the standard of care. And that's sort of how it works. I want to talk a bit about what are our current research interests. So we here are members of ComNets. ComNets is Canada, Australia and New Zealand, and we have generally an annual conference. It's a research group, and we are focused on NET tumours. Why do we partner with Canada? Canada and Australia have a very similar history, and we also have very similar health systems. And so it's easy to work with Canadians because you don't have to deal with a very disparate health system. For instance, the US health system is entirely different to ours, and it makes working with them not always easy. So here we are toughing it out in Hawaii and for our last meeting, and as you can see, Meredith is front and centre there. I'm stuck here, way somewhere up here.
Oh, there you are.
There I am. Yeah, there I am in the back there. So generally speaking, it's a research meeting. We work from around about 8:30 in the morning through till 6 o'clock at night. And then traditionally in the middle of the night there's a dinner. After the dinner it's traditional that we go to a karaoke bar. And Meredith and I were set up, weren't we? Well and truly. Somebody dobbed us in to sing Wuthering Heights by Kate Bush. It was awful.
It was terrible.
It was terrible.
Can you do it
Anyway, we're
No.
still alive. So, just going to talk about some completed trials that we've done here at Fiona Stanley. So the first one is what I call the pituitary study. It was a trial that came out of ComNets. What happened there? That's in the wrong order, sorry. So pituitary dysfunction following peptide receptor radiotherapy for neuroendocrine tumours. I know this is a very busy slide. The reason I put it up was to show you where we all came from. You know, here we've got Waikato in Auckland, we've got Royal Brisbane, we've got Monash, we've got University of Otago in New Zealand, Monash in Victoria, and here we are in Western Australia. So it was a widespread collaborative group. The pituitary gland is about the size of a pea and sits at the base of the brain and controls activity in the thyroid gland, ovaries, testis, lactation and adrenal glands. With peptide receptor radiotherapy, the pituitary gland receives a very high dose of radiation. So the question was, if you've had peptide receptor radiotherapy, does your pituitary work 5 or 6 years later, or has it been fried from the radiotherapy and doesn't work anymore? So here it sits here in the pituitary fossa, just in here. This black is air, so that's your nasal passages, ethmoid sinus. This is your brain up here, and it sits here. And this is a patient receiving a peptide receptor radiotherapy, and it's glowing. And you can see that the pituitary gets quite a dose. It was a multi-centre study. 66 patients with unresectable neuroendocrine tumours, 34 had received peptide receptor radiotherapy, 32 had not received it, and they were the comparison. And the conclusion was that there was no evidence of pituitary dysfunction 5 or 6 years later. And that's often the case with research. So it was useful data. We don't have to check particularly for pituitary dysfunction 5 or 6 years later. You'll often be accustomed to seeing positive results, and you don't read about trials where it didn't really work out as we thought it was, but it's commonly the case that we do studies that are important, and negative studies are important. Some of you would have been on control nets. So that was a study that was initiated between Harvey Turner, who worked here and at Fremantle Hospital, he's now retired, and Nick Pavlakis at Royal North Shore in Sydney. There was essentially 2 trials in one. So for pancreatic nets, it was a randomised study. The randomisation was chemotherapy, which was capecitabine temozolomide, versus peptide receptor radiotherapy plus chemo, asking the question, which one was best in pancreatic nets? Because certainly in Europe, anyway, capecitabine temozolomide would be regarded as the standard first-line therapy for pancreatic nets. For small bowel nets, everybody got peptide receptor radiotherapy, but half the group got some chemo as well, and that was capecitabine temozolomide. Here are the authors. And as you can see, a big group of Australian hospitals all getting together to run this study. This is the patient cohort. This is the sort of stuff that docs look at. Was the study population representative of the population that we see and we're treating? So we do age, gender. This is the grade of the tumour that Chris mentioned about whether they're grade 1 or grade 2, how much treatment they'd had previously, etc. And this is one of the primary endpoints. So this is what we call progression-free survival curve. And on the vertical axis, you've got the number of patients. This is the percentage of patients that are progression-free. In other words, your net tumour hasn't got worse. If it was stable or staying the same, you're progression-free. When it gets bigger, you've progressed. And this is time. And I think everybody, when they started this study, thought that the combo was going to be better. And it didn't work out. These curves are not statistically significant. Where's my mouse gone? Here it is. But this curve here is the peptide is no chemo. And this curve here is the one with chemo. And clearly the combo is not going to be better, you know. And so that's useful information. And so things, you know, sometimes you do clinical trials and you sort of guess and you think, oh yeah, this is all going to be great and we're going to make things better. We need to do the trials, we need to do the randomisation to make sure that the ideas that we have in our head are true. So, but this is pancreas. So for pancreas, it was the reverse. So the peptide receptor radiotherapy arm did a lot better. This is the chemo alone arm. As you can see, you know, there's a big difference between these two curves. And so we would not give, as first-line therapy, we would not give chemotherapy alone. We give peptide receptor radiotherapy. So, very occasionally we combine it with chemo, but certainly we would not give chemo alone as our first-line therapy for PRRT. So for pancreas nets, I mean. This is just how, you know, what side effects did we get? On the whole, wasn't too bad. This is a bit of a worry though. There's this myelodysplastic syndrome. It's permanent damage to your bone marrow and possibly can lead to leukemia. So the incidence in the NECA study was 2%. So that is a concern when you're giving peptide receptor radiotherapy. The main problem to your health though is your net tumour. But so we do use it, but we don't use it lightly. And there has to be a good reason to give it because it can have some adverse side effects. NABNEC was another study we did. This is in high-grade tumours. Chris's talk was focused on low-grade tumours. We did the NABNEC study, which is high-grade tumours, and it was a randomised study of 2 different drug combinations. The study is now closed. We closed about 1.5 years ago. The final analysis has now been completed. The results of that are embargoed, and they'll be coming out probably 6 months, I would have thought. They'll be published. That's what happens in trials. You don't get the results straight away. So that study is closed. So it was open for a while. We've done the study. We've got our number of patients. We've done the follow-up. Final analysis is just being worked through now. So what do we have currently open for patients right now? So we have NET Sanguis, and that is a trial looking at the utility of circulating tumour DNA. And the question being asked is circulating, so just to give you some background, when you've got a cancer, it throws off DNA and you can measure those fragments in the bloodstream. And it's asking the question, is circulating tumour DNA a better measure of how things are going than traditional imaging? So, you know, to have traditional imaging, we use gallium PET scans or CT to work out what's happening with the treatment. We use the traditional measures to work out what we're doing. We take blood samples at the same time, and they will be analysed at some stage in the future and to see which is the better test. We have Sorrento. So Sorrento is an international randomised study, and there's about 30 countries involved in this study. They're looking, the trial drug is a new SSA, a new Somatostatin Analog, so some of you will be on lanreotide. It's supposed to be better than lanreotide. The advantage of the new drug is that you can give it through an insulin needle, so it's tiny. And
And it doesn't need to be refrigerated.
Yeah, it doesn't need to be refrigerated, and you get a higher dose. So they worked out the bioequivalence, so it's the standard, certainly in this will be lanreotide, the control will be the Sorrento drug, which we think will give her a higher dose and a very easy administration. You'll be able to self-administer. Admittedly fortnightly, but hey, you know, it's a tiny needle, you know. So that'll be very interesting to see, you know, how that pans out. That'll take a few years to read out. As we mentioned, we've got the Planet database, which we're keeping in mind. And for high-grade tumours, we currently have a thing called MOST circuit. That's taking a basket. It's what's called a basket trial. Pardon?
Not a basket case.
No, basket trial. So the reason we call it a basket trial is that there's a lot of rare cancers around, and they've taken some rare cancers and put them all in one study. And so, and high-grade nets and intermediate-grade nets are one of the tumours they've chosen for that study. The other tumours are gallbladder and biliary. So, anyway, but these days, cancers are becoming more increasingly classified by their molecular signature, and that means you never get really big numbers, so you have to do these what we call basket trials. Trials opening soon. AusNet should be soon.
Beginning of September is Queen Elizabeth, and I would say that Fiona Stanley will be the next one after that.
Yeah. So this is an unusual trial. You know, I'm a medical oncologist. So this is like
Got no drugs.
got no drugs in it, you know. So AusNet is standard of care, and then AusNet will fund some additional nursing time. So you heard Meredith talking about NECA and stuff. We're fortunate, you know, Australia's healthcare system is not completely uniform, but we're very fortunate here that the Department of Health has funded Lauren and Joe. Now that's not the case in every state. So AusNet's going to be difficult to run here because we already have a pretty good support service provided by Lauren and Joe. The question will be providing a bit more make a difference? And who knows? Now so what's happening on the international scene? So this is a fantastic resource. If you're a medical oncologist like me, you go, it's great. So what is it? It's run by the NIH in Washington DC, and if you're running a drug trial, you're supposed to register your trial with this group. So this gives you every drug trial in the Western Hemisphere that's going on anywhere. I don't know, probably in China they might not be doing it, but certainly in Europe, South America, North America, Australia, and most parts of Asia, if you're running a trial, you put it on this registry. You can go and look at this yourself if you want to. It's public. So I put in carcinoid to see what came up because I thought, I put in NET, didn't seem to look so good, so I thought I'd use the American term and put carcinoid, and this is what came up. So not yet, so not yet recruiting. In other words, they're about to open. There were 6 currently recruiting. In other words, open now for trials for patients to go on. There were 28. No longer looking for participants. 11 completed, 115, and terminated was 28. To give you an idea of the volumes. And what sort of studies were they? just to give you a sample, this is a clinical study to assess the combination of two drugs, which is PRRT plus and nivolumab. That's a immunotherapy. So that's being run in Spain. Lutathera, which is the trade name for PRRT, plus some drug that doesn't even have a name yet. And so it's just called ASTX727. That's being run in London. There's a targeted alpha emitter therapy. That's a new type of peptide receptor radiotherapy. That's being run in Houston, Texas. I assume that's the MD Anderson. There's a novel technetium somatostatin antagonist as a used as a diagnostic. That's in Austria. And here's another one looking at circulating tumour DNA in Belgium and Cyprus. So the purpose of today's talk was to give you a bit of an idea of what trials have been done in the past and how they've helped us in the management of neuroendocrine tumours, what we're currently doing, and we've got a number of trials open and some that's going to open. What's the Australian group doing? Well, really we're ComNets because we aren't big enough to run decent trials just in Australia, so generally we need multiple countries involved, and so that we meet we've got a meeting in November, haven't we? And in Christchurch, so we'll be there. And then the other purpose of today was to give you an idea what's happening on the international scene, the number of trials, the research activity, to see what's going on around the world. Thank you. There we go, escape. There we go.
Thank you to all our speakers. Now we have got Q&A. I know the time is ticking by quickly, so I don't want to sort of keep you here too long, but does anybody have any specific questions that they would like to ask our experts that are here? Okay, well I can do it if you want me to. Okay, so I'm not sure who's going to put their hand up to answer it, but we've got somebody who is interested in knowing what the experts think. Read the following. Given the risk factors of osteoporosis include chronic liver disease, malabsorption, anorexia, malnutrition from any cause, plus all the other factors we know about like age and postmenopausal women, should a stage 4 G1 pancreatic neuroendocrine tumour patient be screened and or preventively treated for this?
Do a Dexapil. Do that or?
Whoever's going to answer, can they?
So wearing a different hat, I do osteoporosis scans, and so all Australians over the age of 70 are eligible to have their bone density measured, which is a pretty simple test, free of charge. It's paid for by Medicare for screening for osteoporosis. Now, the older you are, the more of a risk osteoporosis is, and low bone density in young people is rarely an acute problem. It might become a problem for them 20 or 30 years down the track, but it usually isn't a big issue at the time. Now, anyone with a chronic nutritional disorder, so that can be a bowel problem, it can be a drug-induced nutritional problem, such as some of you will face, it can be anorexia, is at heightened risk for osteoporosis. But we haven't documented markedly impaired bone density in NET patients compared to patients with other things or the healthy population. So I don't think anyone can give you an authoritative answer on this, except that if you have a chronic medical condition which is affecting your nutrition, it's not unreasonable to check out what your bone density is, and that would be the best test to do. And if it's very low, even if you're not old, it's not unreasonable to recommend that you might do something about that. And the thing that you would do would be to take some calcium supplements and maybe some vitamin D supplements. But it would be unusual for young people to need more expensive anti-osteoporosis treatments. If you're older, doesn't matter if you've got NETs, it's recommended that you be checked out. So it's something that we would be happy to perform on NET patients here at this hospital free of charge if there's a good reason. If you didn't have the test in a public hospital, you'd have to pay for it because you wouldn't qualify for Medicare funding. It's about $100, I think. And if you're over 70, you get it for free no matter what your health status. So, yes, is the answer, I guess.
So going on from there, would you get a referral from your GP
Yeah,
to come here?
yeah.
And
Or from the NETs,
coming in and seeing us
or
here
from
in
the
the
NETs
clinic.
people.
If you're worried about it, say, oh, you know,
we,
think you should have a should I have a bone density?
well, coming from Bunbury, we work between Bunbury and here. So we don't actually go to the cancer centre here anymore. We see the
See the
doctor.
Yeah, I don't think you could get it for free in Bunbury. You'd have
No, I don't think
you'd
someone
have to
will
pay
get
for
anything
it.
free.
I go to
Yeah.
Global in Mandel and just changed their name to something else, but they were Global and it was free.
Yeah.
And I'm over 70.
Yeah,
Yeah.
okay.
Yeah.
So there's a birthday sort of reward for turning 70. Yeah. There's not many, but that's one. Yeah.
Mine was free.
Yeah. And but you know, if it's something that's of a concern, I mean, NET patients have chronic nutritional issues. So, I mean, look, women with breast cancer, we screen them all for osteoporosis all the time.
Yeah.
And
Further to that, being screened in Bunbury to here, is there a problem if we normally have pets here and then we have a pet in Bunbury for any reason? Is that because of the different people reading it? Would that be a problem?
So, all of the scanners have very minor performance differences. It's a bit like the difference between a Mazda and a Toyota. You know, they're generally both okay, but the readers are different. The main issue, though, is that if you have your scans in more than one place, the person reading the scan might not be on quite the same wavelength as in point A, so you get variation in the way scans are read. Some people might be more or less experienced in different places, but most importantly, we can't see the scans that are done in the other place.
You can't.
No.
So that means the MDT wouldn't be able to see the scans?
Well, we have to ask for them. We have to know it was done, and then we have to ask for it, and then they send it up the phone line, and it may or may not arrive. And if it does, we may or may not get the report that accompanies that scan when we have to read it again, which is a pain in the backside. And so it's just a management issue, having your scans in lots of different places.
So it'd be preferential just to stay with Fiona Stanley?
Well, yeah, but I mean, if that's a 200-kilometre drive, then that might not be a good idea.
Yeah.
But it's preferable on the whole to have your scans in the same place if you can manage it. Chopping and changing a lot. So some patients get their scans in 3 or 4 or 5 different places, and that's a nightmare.
Yeah, no.
And you can have a bone density test immediately before your PET scan.
Oh, really? So you can have it all in one? Oh.
Yeah. I mean, it needs to be booked, but that's possible.
You mean we can't just walk in and say...
Well, you can, but you'll probably walk straight out again. Okay.
Depends on the luck of the draw when you walk in.
There's just one other question that we had come through, and it's between David and Chris as to, it's quite broad, but whether you can sort of succinct it. How does chemotherapy work, and what happens in chemotherapy if NETs has metastasised from small bowel to liver, and does chemotherapy work on one area?
Do you want me to take that? Yeah, it's your bit of the talk.
So there's lots of different chemo drugs, and they all work in different ways. But the general idea is cancer cells grow quickly, and so there's a cell cycle. It starts off as a cell, then it goes through a process of dividing and making daughter cells. And the chemo drugs work best when cells are growing quickly and dividing quickly, and they interfere in some way in that division growth process, and there's different parts of that growth process that different drugs work on, but it's somewhere that's working over. That's why if I went back to my talk and I had all the green side where the cancers are low grade and grow slowly, that's why chemo doesn't work that well there, because they don't grow quickly. And so, whereas on the other side where it was red and they're growing quickly, the chemo works better. So chemo is either given in tablet or injection form, and so it goes all through your body, except for the brain. It's not very good at getting into the brain. So the idea would be if there's cancer anywhere in the body, excluding the brain, it should, if it's going to work, it should work in all those spots. That's the theory. In practice, we don't see that at all. We see that it works better in some parts of the cancer. It might have started in the small bowel and spread to the liver. So it might work in the small bowel, not in the liver, even though that liver cancer is the same cancer. So there's a daughter cell of where it started. Why that happens, there's a million kind of theories, but it should work everywhere. But yeah, I'm not sure if that answers the question or if you've got anything to add, David.
Well, the treatment, when you give chemo, it goes everywhere.
Yeah.
So it doesn't differentiate which side it is generally, except the brain. The chemo doesn't get well into the brain.
It's going all through your body. It's being absorbed into the blood, so the blood's going all through the body, and so the chemo goes through the blood to all parts of your body.
And I think the question was specifically in relation to small bowel.
Yeah.
Right.
And liver.
And liver. So it should work in those spots. Yeah, it should work in all of those areas. So that's why for a patient who's just got cancer in one spot, say the small bowel, started in the small bowel, we would say to the surgeons, resect that cancer, all the cancer's gone, and that's good. What happens is the cancer starts in the small bowel and then it slips off through the blood and ends up in the liver. So like David said, there would be the scans pick up anything kind of that big. So there would be cancer cells floating around in the blood that we don't see on the scan. We don't have a test good enough to pick up. So we could maybe cut out the cancer in the small bowel and the cancer that started in the small bowel and spread to the liver, and we could cut all those bits out. The cancer's going to pop up somewhere else because there's cells of cancer floating around the blood that we can't see on the scan, and it's going to pop up in another spot in the liver or in the lung or in the bone or wherever, 3 months later. And so you've gone through that big operation, you've still got cancer. It's, was that a good thing to do? That's why, as a general rule, for those patients where it's metastatic, we can't cure them by cutting it out because it's floating through the blood even though we can't see it on the scan. That's why you need treatment that goes through the blood that can go to all the parts of the body through the blood. I think that's...
Yep. Any other questions at all? Yes.
Can pits be spread to the bowels? Pancreatic nets? Can they spread to the bowels?
They're more likely to spread to the membranes surrounding the bowels than to the bowel themselves. I don't know how many of you have done much in the way of butchery, but our bowels are all suspended inside this sort of membrane, almost like sort of glad wrappy stuff, and that membrane's called the peritoneum, and when NET spreads outside of the pancreas or the small bowel, it not infrequently goes into the peritoneum, and there'll be lots of little spots of tumour in the peritoneum, some of which we can see on scans, but often we can't. Sometimes the surgeons do an operation and then when they cut open someone's tummy, they find lots of tumour in the peritoneum and then they say, well, we're not going any further. And you can also get lots of different nets arising from different bits of the bowel or different bits of the pancreas. So someone might have one net tumour in their pancreas, another person might have 2 or 3. Someone might have one net tumour in their bowel, another person might have 2 or 3. Sometimes we don't know if one has spread to the other. Is it in the bowel or on the bowel in this membrane? Or are all of their cells prone to giving rise to nets, and so several can arise at the same time?
There was one more. Yep.
I'm just curious about, we hear a lot about immunotherapy these days, but I understand it's not relevant for nets. Is there a particular reason, obviously a reason for that?
It doesn't work.
Yeah.
Generally speaking, for low-grade tumours, immunotherapy, they've done the trials and it doesn't seem to be effective. And, you know, we talk about, you know, they just don't generate an immune response. And so you can't, if they don't generate an immune response, you can't alter that process.
Yeah. I mean, it's part of that basket, the most circuit, that they're looking at immunotherapies for some nets. But
So they were high-grade tumours.
Yeah. So they're aggressive, dividing really quickly, and that sort of is where it sort of has worked best in other cancers.
But it is a trial.
Yeah.
So that means we don't really know. If we really knew and thought that it was the terrific, we wouldn't need to do a trial.
So cancer's very tricky. So every cell that is a cancer cell started off as a normal cell, and then it's like survival of the fittest. It developed some mutation that allowed it to grow quicker than what it should. So some cancers, the mutation that they have got that allows them to grow very quick is that they're very good at hiding from the immune system. So the immune system should be killing the cancer, but it's not, and that's the survival advantage it got. So for those cancers, immunotherapy works really well because the advantage that the cell had has we have the drug that treats that advantage. Some other cancers, they've got some other mechanism by which they just grew and grew and grew, but it wasn't from hiding from the immune system. So making the immune system better really doesn't add much. And why is some more than others? And what particular mutations have given the survival advantage? You know, we're finding more and more, but there's still more we obviously don't know.
Okay. Well, I think that sort of is all for the quiz. No? Oh, sorry.
Just had a question with the gallium PET scan. I like in the small bowel, but there's also like a spot on my spine. So could that just be like a thing, or would that be something that needs to be looked into?
Nets do spread to the bones. It's
So
not
on that
there.
test, would it be valid on that test to go?
If
for
you've got a hot
investigation?
spot in the bone on a gallium PET, it's, without having seen the scan, it's pretty suspicious that it would be a neuroendocrine metastasis to the bone. They usually don't cause a lot of trouble in the bones. People can have several metastases in their bones which aren't causing them grief. And our level of worry about spread to the bones is not high. You know, liver and peritoneum are much more likely to make you sick than spread to the bones. There are also some non-cancerous things which can cause a little bit of uptake on a gallium PET scan in the bones. So that's why I said without having seen your scan it's a bit difficult to know, but most people, if they've got metastatic spread of their neuroendocrine tumour to organs like the liver, for example, and we see a spot in the bone, it's probably a metastasis as well. But they tend to do nothing much for a long time. if you've got to choose a place for it to spread, that's not a bad one.
I just have one question. I know where my secondary cancer is in my stomach, but we don't know where the primary is. How do you find out where the primary is?
Sometimes we never know. We call them unknown primaries, and it's about 20%, isn't it?
I think it's probably a bit lower than that, but certainly it's 10.
Yeah.
You just
So
don't know.
10 to 20% of people, we just never know where it
Because I
started.
thought it might have been in the lower bowel, but when I had one of the medical fellow that was checking a blockage in my throat, he was putting the camera down, and I said, how far down do you go? He said, just past the lower bowel. And I said, would you do me a favour while you're down there with your camera? just see if you can see any cancer in my lower bowel.
Yeah.
Anyway, he came back and he said, I saw some lymph nodes, but there was no cancer. So it's not down the lower.
It's not just nets either.
Where the heck
There
is
are
it?
other cancers where we never know where they started.
You don't know. Wow, and there's no way to find out.
I mean,
You know, the other one's in
melanoma's
my
one
stomach.
where,
The
you know,
secondary's in my stomach, about the size of an orange, but that's it. That's all we know.
and we think what sometimes happens is the original cancer, for some reason, dies off, but where it's spread doesn't. Or the original cancer is tiny, you know, less than a pinhead sort of thing, and no one will ever find it. But it's
And the other thing that can happen with a colonoscopy, all they're doing is looking at the inside of the pipe. All they see is the inside of the pipe. If the problem is on the outside of the pipe, they don't see it.
Or very deep in the pipe.
Or buried deep in the pipe, you know.
yeah.
So you can have a colonoscopy and it's sitting there and it's breeze on past, you know.
Yeah. We've got one more. This is the last
I just
question.
want to do a quick plug. I just want to let everyone know that the next WA support group meeting is in the room next door on the 4th of October. And we do have a guest speaker coming along. She's going to be talking about doing advanced health directives.
That's Sabina.
Yes, Sabina.
She's really good.
From Palliative Care. This would be the third time she's been to us, but she's really good, and she's going to be looking at doing advanced health directives with people. So if anyone that hasn't ever been to a forum, a support group, you're very welcome to come along.
6 to 8?
6:30 till 8:30.
6:30.
Yeah. And just a quick thank you to Meredith, Simone, and to everyone here. Thank you very much.
And to the doctors.
Yes. So thank you so much to all our speakers. It's been amazing and a really informative forum. So I hope you all got a lot out of it. And we've just got one more thing to do, which is who, I don't know, and I'm not looking or anything, but who's in B11?
What is that?
You have to look at the bottom. So lift up your seat. We're on the bottom.
That's me!
It's you? Okay. So we've been given some absolutely beautiful artworks. 1, 2, 3 by our beautiful artist up the back there, Mel. So B11, you get to choose which one you'd like to have. But thanks again, and this has all been possible by Novartis, who have actually sponsored the forum to have the filming and everything done. So thank you to everybody, safe travels home, and we'll hopefully see you before 2 years, but otherwise we'll see you in 2 years. Take care.